They persisted.
Abstract number 026. Abstract number 026.
వాళ్ళు చేసుకోవచ్చు రా, మనది వాళ్ళకి వినపడుతుంది కదా.
Hello. Why not Swami Sahib?
ఫస్ట్ నేర్చుకోవచ్చు. सर कैन बी रेडी बोल के पूछो, पूछे बाद से यस बोले तो सर कैन बी कॉल द डेलीगेट्स बोल के बोले तो
Hello, Swami sir, can we start the meeting? The delegates are waiting. Hello.
Hello. Hello, Swami sir, can we start? Hello. Swami sir.
Yes, go ahead.
అయినా పాస్ కూడా అడుగుతుందంట అన్న అయితే జన అన్న
Hello. Hello, Swami sir.
Yes.
Sir, can we start?
Yes.
అయినా పాస్ కూడా అడుగుతుందంట
Dr. K.S. sir, Swami sir, no?
Yeah.
పాస్ కూడా అడుగుతున్నా
Can we call the delegates?
Yeah.
Serial number 1, abstract number ABS 026, and name is Hari Priya. Hello. Hari Priya. Sir, Hari Priya is not there, sir.
RPI is not there.
No, sir. The
You
next
can- you can go to second
Anurag
person.
Memula. Hello, Anurag.
Second one,
Anurag.
Dr. Anurag Vemula.
Please unmute Anurag. Sir, he is joined just now.
And
Hello, Anurag. ABS 07079 abstract number and serial number is 2. Please unmute.
Yeah. Hello.
Anurag, Dr. Anurag.
Yes.
Sir, you can start your question, sir.
Anurag.
Hello.
Anurag.
Sir,
Tell
your
your
voice.
paper title.
Yeah. Tell me your title. Anurag. Hello.
internet is not stable.
టాపిక్ ఏంటి?
Hello. Audible?
యా
Get. Sir, you are audible, sir.
Are Sarita.
యా
No, unmute చేయవా? Anurag.
Abstract number 004, Amarendra Reddy, please log in. Abstract number 004, Amarendra Reddy, please log in. Abstract number 015, M. Rajshekar Reddy, please log in. Abstract number 036, T. Madhuleka, please log in.
Anurag?
Yes, sir. I am here.
Yeah. What is your study, Amma?
Sir, clinical profile in the isolated systolic hypertension.
What is that your inference?
Sir, there is mainly the study is focused on the echocardiographic findings and ECG findings, sir. There is a significant number of left ventricular hypertrophy and the left ventricular mass index.
Have you taken a
study
symptomatic? Have you taken a symptomatic individuals or already newly diagnosed individuals?
Sir, they are in the study. We taken mainly the blood pressure, sir. Most of the people are asymptomatic, sir. Followed by that, breathlessness is the main complaint, sir. Followed by that, pedal edema, sir.
Okay.
Significant number is asymptomatic, sir.
Okay. What is your final results?
Most of the studies shown that some amount of decrease in the mainly focusing on the systolic blood pressure, sir. If we decrease that, some amount of cardiac benefit is there.
Are there any treatment?
Yes, sir. They are on the before starting the study, they are newly diagnosed people, sir. They are not on any antihypertensives, and secondary hypertensives also, secondary cause of hypertension also they are excluded.
Okay. What is the drug of choice in isolated systolic hypertension?
We can go with calcium channel blockers. Calcium channel nifedipine, followed by we can use the diuretics, sir. Second line drugs are AC inhibitors. Beta blockers should be contraindicated.
Beta blockers are contraindicated, huh?
Yes, sir. Especially in the isolated systolic hypertension, sir.
Okay. Thank you, Amma. All the best. Thank you.
Thank you very much, sir.
Thank you. Ida 096 Sheikh Farhin Mohammed. Serial number 3.
Hello. Hello, sir.
Introduce yourself, Amma.
Sir, good morning, sir. I'm Dr. Farhin Bano, sir.
Yeah.
And I'm general medicine postgraduate, sir. This
is which place, Amma?
Sir?
Which
sir?
place, Vijayawada?
From Guntur, sir.
Guntur. Right.
Yes,
go ahead, Amma.
Sir, my topic is correlation between serum uric acid levels with severity of acute myocardial infarct, sir.
Yeah. What are your observations?
Sir, elevated levels of serum uric acid levels was found to be a very good indicator of prognosis, sir, of morbidity and mortality when there is acute myocardial infarct, sir.
What are your values?
It was for 5-day follow-up, sir. In the 5-day follow-up period, there were about 6 deaths, sir, of the total patients. And mean value of serum uric acid level was on the higher side, between 7.32 plus or minus 1.23 milligram per deciliter, sir.
Okay. Do you suggest any specific treatment for these individuals?
Actually, this is like more of to show the prognostic marker, sir. From the day one, when the patient got admitted, if the serum uric acid level was shown to be higher, it indicates higher Phillips class and higher high chance of morbidity in these patients, sir.
So, if you decrease the uric acid acutely, do you think that the patient improves?
Sir, I don't think acute decrease will improve the patient, sir, because the whole pathogenesis itself is a chronic process, sir.
Okay.
So
you would like to recommend monitoring uric acid in individuals with high risk factors for myocardial infarction.
Yes, sir, definitely. Many studies have also shown this, sir. Serum uric acid level is a very important marker for atherosclerotic plaque formation as well, sir. Yes, sir. So it is producing like reactive oxygen species, and it is also increasing platelet-derived growth factor, and it is increasing thrombotic risk, sir.
Okay, okay. Which drugs you use to decrease serum uric acid in otherwise stable patients with risk profile?
Sir, allopurinol can be used, sir, or febuxostat or pegloticase, and also some diuretics. These can be directly used to decrease uric acid levels, sir, if it is because of any other cause.
Okay. Do you think that all these are safe? Are there any significant side effects for febuxostat?
There are side effects, sir.
Okay, okay. You are finally, Ramma?
Yes, sir.
Okay. All the best. Thank you.
Thank you, sir. Thank you.
Karthik. Dr. Karthik?
Can you hear me, sir? Hello?
Karthik?
Hello. Yes, sir. I'm Karthik.
Yeah. You are from?
Vijayawada, sir. Siddhartha Medical College.
Yeah. Siddhartha Medical College, important, not Vijayawada. Okay.
Sir.
What is you are finally here? Huh?
Yes, sir. Yes, sir.
Yes, sir. What is your study, Amma?
Sir, study of ECG and 2D echo in patients with LVH, sir. Left ventricular hypertrophy.
What is your observation?
Sir, I observed ECG is not so sensitive and for LVH, sir, but it's specific, sir. And ECG with secondary STT changes have higher risk of morbidity and mortality with cardiovascular disease, sir.
So you have studied
yes, sir.
These individuals, followed these individuals with LVH strain to an event?
No, sir. I have taken 100 patients, sir.
No, you are telling that individuals with left ventricular strain pattern, they develop complications. You follow these patients over time?
Yes, sir. Yes, sir.
Okay. Yes, sir. So what are your criteria for LVH? Which criteria you followed?
Sir, I have followed 3 criteria, sir. SL criteria, Sokolow ion index criteria 1, RE criteria, and the total QRS voltage criteria, sir.
Which is what is the voltage criteria for LVH?
Voltage criteria, there are total QRS voltage criteria, sir. Do you want? Sir, R wave in all the leads should be more than 180 millimeters. Then it will be.
What is
indicative
ventricular activation time?
0.12 seconds.
What is it? What is ventricular activation time or?
Sir, 0.12 seconds. Sir. 120 milliseconds, sir. 0.1.
Okay. So, what is intrinsic deflection? Delayed intrinsic deflection. Both are same?
No, sir. No, sir.
Ventricular activation time and delayed ventricular.
Yes, sir. Yes, sir. Because
Both are
the no, sir. In LVH it will be delayed, sir. Because the left
Which one is delayed?
in LVH, sir.
Which is delayed?
Intrinsicoid, sir.
Intrinsic deflection.
Yes, sir.
That is almost equal to prolonged ventricular activation time.
Yes, sir.
If ventricular activation time is prolonged, intrinsic deflection is delayed. Almost they are synonymous.
Okay, sir.
Okay. What are the V5, V6 criteria for LVH R wave?
For V5, V6, it will be. Are you asking SL index, sir?
Yeah. ST's criteria. What is ST's criteria?
Sir, ST's criteria, there are 6 parameters, sir. For each parameter, there will be individual score, sir. Score more than score greater than or equal to 4 is.
Tell me the criteria points.
Check, first one, voltage criteria, sir. S in V1 more than 30 mm or R in V5 more than 30 mm. Its score is. Yes, sir. Yes, sir. Next criteria, STT depression, secondary STT depression, sir. Next criteria, left atrial enlargement, sir. Next criteria,
left atrial enlargement.
P wave, you can say P mitral.
How do you make it out?
More than P wave with more than 3 small boxes, sir. Next, left axis deviation and intrinsicoid V5, V6 more than 50 milliseconds.
Okay.
All these criteria.
So you have correlated these with echocardiogram?
Yes, sir.
So echocardiogram, you say it is more sensitive?
Yes, sir. Yes, sir.
ECG is more specific.
ECG is more specific, sir.
But not sensitive.
Not sensitive, sir.
Okay. Who is Professor Amma? Sudhakar Gara?
No, sir. Venkat Krishna, sir. H.O. Venkat Krishna, sir.
Sudhakar Gara ekkada?
Guntur, sir.
Guntur transfer ayyara?
Yes, sir. Yes, sir.
Okay, Amma. All the best. All the best. You have done well.
Thank you, sir. Thank you, sir.
Thank you. Dr. Meghana.
Hello, sir. Good morning, sir.
Good morning, Amma. What is your study, Amma?
Sir, a etiological clinical profile and complication profile of cases of atrial fibrillation, sir.
Yeah. Go ahead, Amma. What is your observation?
We have collected 50 cases in our cardiology OP, cardiac ICU, and medical OP, sir. No patient is taken twice, sir, if he is given within the time period of our study, sir. The most common etiology we observed was valvular heart disease, sir. Out of 50
More
cases,
common etiology.
Yes, sir. Out of 50 cases, we have taken 62%. That is, 31 cases are valvular heart disease cases, sir.
Which valvular heart disease is more common in your study?
Most common was mitral
stenosis?
stenosis, sir.
How many cases mitral stenosis you have seen?
In 31 cases, 15 cases were mitral stenosis, sir.
Oh my God.
Mitral stenosis plus MR was 8 cases, sir. Mostly mitral stenosis, sir. Next common thing was mitral stenosis plus mitral regurgitation, sir.
Regurgitation, 8 cases.
Followed, yes, sir. Followed by aortic stenosis and aortic regurgitation, sir.
All are with valvular heart diseases have taken. They have taken atrial fibrillation.
Only, sir. Only in atrial fibrillation, sir.
Okay. So how many cases are of valvular disease? 30 is mitral stenosis, 8 is mitral stenosis regurgitation.
Sir, 15, sir.
38. Yeah? 15, no, 8. Aortic valve? Yes.
15 cases are mitral stenosis cases, sir.
15 mitral stenosis, 8 mitral stenosis regurgitation. Emma?
Hello, sir. Sir, can you hear me, sir? Yes, sir.
Yes, sir, you are audible.
Yes, sir.
Yes. Yeah, mitral stenosis, regurgitation. How many are aortic valvular diseases? Magna, you are muted.
Sir, can you hear me, sir?
Yeah. How many aortic valvular diseases you have studied?
Aortic stenosis cases are only 5, sir.
Only 5. Okay. The remaining are?
Yes, sir. Remaining multiple valvular diseases, sir. Mitral stenosis plus MR plus AS are 3 cases, sir. That's all. But most common thing.
You have not seen any other cases of atrial fibrillation like ischemic heart disease, cardiomyopathy?
No, sir. Within valvular heart disease, we have 31 cases, sir. Next, following was hypertensive heart disease, sir. 6 cases we saw, sir, out of 50 cases.
Yeah.
Followed by ischemic heart disease, 4 cases. Congenital heart disease, 4 cases, sir. And in DCMP cases, we got 3 cases, sir, within these 50 cases.
Any non-cardiac atrial fibrillations you have seen?
No, sir.
No. What is lone atrial fibrillation?
In absence of any structural heart disease, if we have AF, it is called lone AF, sir.
How do you treat them, these particular complications?
Complications of AF.
Fibrillation?
Sir, actually, based on the period of AF, we are classified into paroxysmal AF, persistent AF, and permanent AF, sir. If it is a intermittent activity which is lasting for less than 7 days, then it is called paroxysmal AF, sir.
How do you treat?
Actually, we have to see if AF is within origin is within 48 hours, we can either cardiovert the patient chemically or electrically, sir. If it is greater than 40 years, we have to see for any LA clots, sir. If we have availability of transesophageal echo, we can perform the echo and see if LA clot is there or not, sir. If LA clot is not there, then again we can revert the rhythm, sir, chemically or electrically, sir.
Yeah.
If LA clot is present, sir, we have to give heparin and we have to continue the patient on warfarin, sir. 1 week before the 2 weeks before the procedure and 1 week after the procedure, sir.
Okay.
Sir.
What is fine atrial fibrillation? Fine and coarse atrial fibrillation. Have you heard?
Based on the fibrillatory waves, sir.
Where do you get fine and where do you get coarse? Any difference of likely underlying cause?
No, sir. I don't know, sir.
If it is coarse, that indicates left atrial enlargement,
indicating
a chronic nature of the disease.
Okay, sir.
If it is a fine atrial fibrillation, it may indicate a ischemic heart disease, more likely a acute complication.
Okay, sir.
Do you use Rate controlling or rhythm controlling? What are the rate controlling drugs?
Actually, amiodarone is both rate and rhythm controlling, sir. And other rate controlling drugs we use are beta blockers, sir.
What is the role of digoxin in this particular case?
In cases of with DCMP cases, we can give digoxin, sir. And based on the etiology, if it is due to dilated cardiomyopathy, digoxin has better role, sir.
So, digoxin is indicated with fast ventricular response.
Yes, sir. If in the resting heart rate is greater than 80 or with mild exertion, if it is greater than 110, we have to use rate controlling drugs, sir.
Fast ventricular rate, you consider digoxin, right?
Yes, sir.
Can you give evaporatin?
That is a SA node inhibitor, no, sir.
Can you give evaporatin?
No, sir.
Why?
That is SA node inhibitor, sir. AV nodal blockers are better, sir, to control the ventricular response.
Okay. Okay. Have you seen any complication in these individuals during your study?
Yes, sir.
What are the complications you have observed?
Heart failure is seen in 16 cases, sir. And 2 cases presented with cardioembolic stroke, sir. LA clot is found in 3 cases, sir.
Okay, okay, okay.
The most common complication we found was heart failure, sir.
Heart failure.
Yes,
Congrats, sir. All the best.
Thank you, sir.
All the best.
Thank you, sir.
Next, Sushmita. Abstract number 118.
Yeah. Sushmita? Dr. Sushmita? Dr. Sushmita?
Dr. Sushmita, please unmute your audio.
Kodali Sushmita.
Please unmute your.
వస్తుందా చూడు వాళ్ళందరికీ వస్తున్నట్టున్నా కదా వీడియో వస్తాయా వీడియో ఎక్కడ మందది
Unmute your Sushmita.
Okay, వాళ్ళ వీడియో
సుష్మిత
Sir, she is muting, but she is not unmuting your audio.
పార్టిసిపెంట్ లిస్ట్ లో అయితే కొడాలి సుష్మిత ఉంది బట్ మ్యూట్ లో ఉంది.
సుష్మిత అన్మ్యూట్ యువర్ సెల్ఫ్ అమ్మా.
I am unable to have access for audio, sir. Participant Sushmita Kodali, but then all message చేసింది. I am unable to have access for audio. ఎవరు సార్ నేను చూస్తాను. సుష్మిత. నేమ్ ఎంత
Dr. Sushmita, are you able to hear me?
Please unmute your audio.
Sushmita.
She is not responding. Go for the others.
She is putting a message. Yeah. She is responding. Dr. Sushmita. మళ్ళీ పాతదానికి వచ్చి పాత మోడ్కి వచ్చి.
Sir, she is having an audio problem.
Yeah, she put a S.
Yes.
She put a S message.
You can ask
problem was rectified, it seems.
Okay. Sir.
Sushmita, are you able to hear?
Unable to unmute sir, messages.
She is having an audio problem. You can text her the question.
She is telling that she is unable to unmute.
Yes, sir. You can text her a question.
ఎలాగ టెక్స్ట్ చేయడం?
Gautam Murthy garu.
In the chat box, text.
Can you address the issue?
Sir, you can type the question in the chat box.
Chat box.
My topic. My topic study of emission levels and its relation to erythemas and acute myocardial infarction.
ఇక్కడ ఇది
అక్కడికి వెళ్ళాలి.
ఎక్కడికి?
మనం జూమ్ లోకి వెళ్ళిపోయి ఇక్కడ టైప్ చేయండి.
సుష్మిత దగ్గర
చాట్ బాక్స్ లోనే మనం టైప్ చేసి తనకి
ఆవిడకి వెళ్తుందా, అందరికి వెళ్తుందా?
చాట్ బాక్స్ లో సుష్మిత టైప్ చేసి మనకి సెపరేట్
Sushmita, you will be getting a message.
Sir, ఇందులో టైప్ చేయలేమా సార్?
ఓకే ఇక్కడ
అక్కడ ఒకసారి క్లిక్ చేయండి సార్.
వెళ్ళింది కదా?
Dr. Sushmita, did you get the message?
డైరెక్ట్ గా కాల్ చేసి మాట్లాడచ్చా? ఆ నంబర్ కి డైరెక్ట్లీ దే కెన్ టాక్.
Yes, sir, you can talk.
Hello.
My studies on relationship.
మనోళ్ళే కదమ్మా, మనోళ్ళే కదా? ఇంకా ఉన్నారా ఆ పేరు మీద?
Yes. What is your study?
Message పెట్టింది సార్. 50% of study subjects have low serum magnesium levels on day 1 of admission.
ఇంకోటి ఏదో పెట్టినట్లు చూడు.
It's a cross-sectional study sir అని పెట్టింది సార్ ఒకటి. ఇంకో మెసేజ్ పెట్టింది. Those patients had PVCs and BF during 5-day hospital stay.
Any suggestions అని అడిగాను. మీ పేరు నుంచి వెళ్తుందా? So by giving IV energy for you can prevent sudden cardiac death. Yes. Okay. What is Yes. Are you given in any patient? Nara Sushmita, madam, Dr. Sushmita. చూడు సరిపోద్దా? డాక్టర్ గాయత్రి మన ఆంధ్ర మెడికల్ కాలేజ్ scoring systems, what scoring systems we have followed?
Sir, out of 50 patients, 20 patients had arrhythmia.
మనం వాల్యూ అడిగాం కదా. ఓకేనా? ఇంకో దానికి వెళ్ళిపోదా, ఇంకో కేసుకి వెళ్ళిపోదా.
ఇంకో పర్సన్.
Sir? Hello, sir.
Shishmita Amma? Shishmita?
Sir, this is Abhinaya, sir.
Abhinaya, right. Welcome, Amma.
Good morning, sir.
What is your study? Good morning.
My study is echocardiographic changes in patients with CKD, sir.
Can you come with video?
Yes, sir. Sure, sir. Sir?
Yes, I am coming. Yeah. What is your study, Amma?
My study is on echocardiographic changes in patients with CKD, sir.
Yeah. What is your observation, madam?
We have taken 50 patients, sir. So, who are known case of CKD and in from stage 3 to 5, sir. And who are known case of CKD since 3 months, sir. Without any known cardiac etiology or without any known case of hypertension before the diagnosis of CKD, sir.
Okay. What are your observations?
Our observations are most commonly pericardial effusions were seen, sir.
Yeah.
In among 50 patients, 22 are having pericardial effusions, followed by left ventricular hypertrophy in 20 individuals, sir. And followed by LV dilatation is seen in about 10 patients, sir. And LA dilatation.
LV dilatation or LV dysfunction?
LA dilatation, sir. Dilated.
Yeah.
And which is then followed by systolic dysfunction and diastolic dysfunction. And in only 8 people among 50 individuals, there is no changes, sir, in echo.
What is your recommendations with your study?
So the causes for these changes are usually related to chronic kidney disease like anemia, sir, and uncontrolled hypertension, dyslipidemia, sir, and albuminuria also, which causes.
What are your recommendations finally?
So we should treat anemia as soon as and hypertension as far as possible, sir. With erythropoietin supplementation and regular erythropoietin injections and transfusions if necessary, sir. And other than that, we should also control the blood pressure, sir. With antihypertensives like calcium channel blockers and clonidine, prazosin, and also diuretics, sir.
Okay. Congrats and thank you. Thank you.
Thank you, sir.
Next, abstract number 147.
147.
Serial number 8.
Dr. Muhammad Firoz.
Good morning, sir.
Good morning.
Sir.
Yeah, what is your study, Amma?
Sir, my study was a study of microalbuminuria in essential hypertension, sir.
How do you define microalbuminuria?
Sir, microalbuminuria based on National Kidney Foundation, sir. It was defined as urinary albumin excretion rate of 330 to 300 micrograms per deciliter, sir. In at least 2 out of 3 consecutive urine samples, sir.
Okay. What method you have used locally? You did it bedside or in biochemistry? Dr. Firoz.
Sir, yes, sir.
You did it bedside or you did it in biochemistry department?
Sir, we have taken it from biochemistry department only, sir. The study was
Okay.
from the.
What are your observations? Microalbuminuria and cardiovascular complications.
Sir, as per my study, there was a significant association between the microalbuminuria and end organ damage among hypertensives, sir. In
This
my
is
study,
only in hypertensives or diabetics also?
Sir, I have excluded diabetics, sir. Sir, there was a significant association even in diabetics, sir, but in my study, I have excluded diabetics with microalbuminuria, sir. I have considered only hypertensives with the microalbuminuria and their end organ damage and complications rate among them, sir. So,
you're not mentioned in the title, no?
Sir, I have
you're
mentioned
not mentioned in the title.
Study of microalbuminuria in essential hypertension, sir.
Okay.
So here
any specific treatment you suggest to prevent microalbuminuria?
Yes, sir. We can reduce the microalbuminuria with the help of ACE inhibitors and ARBs, sir, which will cause the afferent arterial dilatation in the kidney. That will reduces the excretion of albumin in urine, sir, among hypertensive.
The renoprotective. The
renoprotective effect, which will help us to reduce.
Okay.
Yes,
what
sir.
are the complications of ACE and ARBs and contraindications?
Sir, ACE and ARBs are contraindicated in renal artery stenosis patients, sir. And the patients who has serum creatinine levels greater than 2.6 with a GFR less than eGFR levels less than 30 ml per minute, sir.
Is it bilateral renal artery stenosis or unilateral renal artery stenosis is also contraindicated?
Sir, it is contraindicated in bilateral renal artery stenosis, sir.
Are they indicated in pregnancy?
No, sir. They will cause no, sir. They are contraindicated in pregnancy due to the risk of decreased amniotic fluid, sir. They will reduce the amniotic fluid, sir. So they are contraindicated in even in pregnancy, sir.
Will these drugs cause hyperkalemia or hypokalemia? Any electrolyte imbalance?
Yes, sir. These drugs will cause hyperkalemia, sir, because of inhibition of aldosterone, sir.
Okay. Can you combine ACE and ARB?
Sir, actually, there was no beneficial effects with the combination of ACE and ARB, sir. No, sir, we won't use a combination of both ACE and ARB, sir.
Is it safe? Is it safe?
No, sir.
Why? Hyperkalemia is a significant problem if you combine these two drugs. So never combine AC with ARB.
Yes, sir.
Congrats, Amma. Thank you.
Thank you, sir. Thank you very much.
Thank you.
The next abstract number 169. Venkata Sai Suresh Atula. Please unmute.
Venkata Sai Suresh. Venkata Sai Suresh, doctor. Dr. Venkata Sai Suresh. గంట పట్టిందా ఎన్నయ్యే 8 అయిపోయింది 7 నిమిషాలు పడుతుందా
Venkata Sai Suresh, please unmute.
Venkata Sai Suresh.
Unmute yourself, Venkata Sai Suresh.
నలభై మూడా Venkata Sai Suresh, please unmute yourself.
Initial is Akula. Initial is Akula.
మన హెల్పర్ అడుగు. హలో హలో
Suresh Akula, please unmute.
డాక్టర్ సురేష్
బాబు మాట్లాడుతున్నారు. బాబు మాట్లాడుతున్నారు. సురేష్ బాబు.
Sai Suresh Akula, please unmute.
హలో
Venkata Sai Suresh, please unmute.
సాయి సురేష్ బాబు అంటే మీరేనా? ఆకుల వెంకట సాయి సురేష్ అని మీరు?
From Karnool Medical College. Venkata Sai Suresh Akula from Karnool Medical College. Please unmute. We are from which place? Which medical college? Suresh Babu, am I audible?
Sir, మన side నుంచి problem
Hello.
Hello. Venkata Sai Suresh Akula from Karnool Medical College. మళ్ళీ పిల్లమని మనోడు ఎవరో ఉన్నాడు కదా హెల్పర్.
Venkata Sai Suresh, please check your internet connection.
Hello.
Hello.
Is he coming, Amma?
Don't know, sir. I think he's having internet issue. He's not audible.
Okay, give him a message that he can call back whenever he is available.
Okay, okay.
We'll go to next one.
Yes, sir. The next one.
Put a message.
Okay, okay, sir.
Put a question and chat box.
Yes, sir. You can keep. You can put it. Sir.
Put chat box.
Better, sir.
Venkata Suresh. Venkata Sai Suresh Baba.
Sai Suresh Babu.
Jana. Sai Suresh Babu. Jana.
Please, everyone, rename your names. Rename your names. Please rename your names to original.
మెసేజ్ వెళ్ళిందో లేదో తెలియదా మనకి?
తెలుస్తుంది సార్
ఎస్ఎంఎల్ కూడా
అక్కడ
వెళ్ళవా?
వెళ్తుంది సార్,
హలో,
మెసేజ్ వెళ్తుంది.
వెళ్ళిందా?
అంటే అది మీకే కనిపిస్తుంది సార్, మెసేజ్ వెళ్తుంది.
ఓకే. ఆయన మాట్లాడుతున్నారా మీతోటి?
మాట్లాడచ్చు సార్, మాట్లాడట్లేదు. అతనికి ఇంటర్నెట్ ఇష్యూ ఉన్నట్టుంది, అతని వాయిస్ రావట్లేదు.
అతను ల్యాండ్ లైన్ కాల్ చేస్తారా?
ఓకే సార్, నేను కాల్ చేస్తాను, నేను కాల్ చేసి చెప్తాను అతనికి.
కాల్ చేసి రీషెడ్యూల్ చేయండి, లేకపోతే మాతో డైరెక్ట్ గా ఫోన్ లో కాంటాక్ట్ చేయమనండి.
ఓకే సార్, ఓకే.
నీ నెంబర్ ఇస్తా? నీ నెంబర్ ఉందా? నీ డాక్టర్ గారి నెంబర్ ఇస్తారు, ఆ నెంబర్కి డైరెక్ట్ గా కాల్ చేయమనండి.
నాకు చాట్ బాక్స్ లో నంబర్ పెట్టండి, పర్సనల్ గా పెట్టండి.
నీ నెంబర్ పెట్టు.
నేను
చాట్ బాక్స్
లో పెట్టిన
చాట్ బాక్స్
గౌతమూర్తి గారికి
గౌతమూర్తి నాకు పెట్టండి పర్సనల్.
We'll go to next one.
Yes,
I'm
yes, sir.
currently posted in ICU, should attend serious case. So I would like to finish it early. So I want to present now, sir. And I am also having nut issues. Krishna Sagar Reddy. Krishna Sagar Reddy గారిని తీసుకోండి.
Sir, is it audible, sir?
Krishna Sagar Reddy, yes, audible.
Sir, should I go on, sir?
Yeah. You are? Introduce yourself, Amma.
I'm Dr. Krishna 3, sir.
Yeah, what's your name?
Krishna Sagar Reddy, sir.
Yeah. What is your abstract number?
Abstract number is 344, sir.
344. You have any serial number?
Serial number is 22.
Yeah. What is your study, Amma?
Sir, my study is on a prognostic significance of serum uric acid levels in patients with acute myocardial infarction, sir.
What is your observation?
So I just want to look for the prognostic significance, whether it's with the serum uric acid or not. And serum uric acid along with the cardiac failure and arrhythmias associated with serum uric acid with acute myocardial infarction or not, I want to study, sir. So what I came to the conclusion is that serum uric acid has a strong evidence of arrhythmogenic events in acute myocardial infarctions.
How many cases you have seen?
Cases, out of them, so in increased serum uric acid levels, heart failures were total 41 I observed, sir.
Yeah.
And arrhythmia was also 7, sir, when compared to the normal uric acid levels.
What is your recommendations finally to the patient? Or
So,
to the
total I studied for a study of 10 days, sir. So the first day on the admission also, we should take the serum uric acid level. On the subsequent day, first week and the 10th day also, we should see for the serum uric acid level, sir. If it is elevated, then we can suspect for the acute
how will you treat hyperuricemia?
Sir, if generally in normal patients, if it is above 9 or 10, we'll go for the Febucostat 40 mg BD, sir.
Okay.
So if it is not 6 to 7, we'll observe without joint pains.
Have you treated these patients with Febucostat? Individuals with elevated uric acid?
Studied the association between the acute heart failure and the acute acid. It did not give any support.
You are not poorly audible. Have you given to any patients?
No, sir.
Not
after discharge, sir. After the day 10th, we kept him on
you
medication.
Put them on
yes, sir.
Anti-hyperuricemic drugs, sir?
Yes, sir. Yes, sir.
Okay. Thank you, Amma. Thank you.
Thank you so much.
Please attend your emergency.
Thank you so much.
Thank you.
I will go for the next.
1 minute break, Ivane.
Okay.
Yes, next one. Gautam.
Yes, sir. Next one is abstract number 174. Miyapuram Yashwant.
Abstract serial number 10 పక్కన అడగదు.
Serial number 10.
Yeah. Dr. Yashwant.
Yes, sir. Good morning. I'm Yashwant, sir. Finally, a postgraduate. I'm doing
Which medical college?
Vinayaka Mission Medical College, sir. Karaikal.
Karaikal.
Yes, sir.
Pondicherry.
Yes, sir.
Okay. Which year you are?
I'm in the final year, sir.
Yeah. What is your study, Amma?
Sir, my study is on the clinical and risk factor profile, sir, in the young adults with acute coronary syndrome. It's a case control study, sir.
Young adult means what is the age you have taken?
Less than 40 years.
Less than 40?
45. I'm sorry, for 45. From 8 to 45 years, we have considered in the study, sir.
Okay. What is your observation, final observation?
The observation was smoking, alcohol, hypertension, diabetes, dyslipidemia, and family history. These were significantly
What is the IBD, sir?
Family history, sir.
Not audible clearly.
Family history, sir.
Family history. You have told smoking, alcohol, hypertension, and
diabetes.
Diabetics. Okay.
Diabetes.
I had it like IBDs. Okay, diabetes.
Diabetes, sir, and dyslipidemia and family history were associated, sir. And
how many of them are modifiable and how many of them are non-modifiable?
The modifiable, there were mainly alcohol.
So alcohol, all individuals or alcohol in high doses?
45% patients in the study group were alcoholics, sir.
No, alcohol is supposed to be protective according to some studies, no?
Yes. But what we found is that around 45% of them were alcoholics in our study.
So alcohol excess in moderation is risk.
Yes, sir.
If you cut down to social drinking like 30-60 ml a day, do you recommend?
Yes, sir. We have recommended, sir. We have recommended the patients to cut down on alcohol, sir.
No, normal individuals, you ask the patient to consume alcohol to prevent coronary events?
No, sir. Usually we advise them not to abstain from consuming alcohol.
Consuming. Is non-taking alcohol is risk factor for myocardial infarction? Just in the other way I am coming.
Yes.
I read some article and stunned. I read people not consuming alcohol, they are a risk for myocardial infarction. I was stunned and surprised to hear such an article.
That is quite interesting, sir. So I'll go back and I'll refer that article, sir. This is the first time listening to this.
So this is a Western study, and the risk factors they have studied are people not taking alcohol.
That's quite interesting. This was first time listening to this.
The person must be having a alcohol industry.
Okay. Yes, sir.
Yeah. What is your observations?
So, sir, among the
which is most common, smoking or diabetes, hypertension?
Diabetes and hypertension was more common, sir. Around 75% of the study
in 45 young people, diabetes and hypertension.
75% were hypertensive.
Okay, they are too early to have MI in as a risk factor. What is the duration of these hypertension and diabetes in these individuals?
Sir, actually, we have not included the duration of the diabetes and hypertension, sir. What we have included the pressure values. Pressure values, systolic pressures were approximately around 145.
Yeah.
Whereas in the placebo group, the mean value was around 132 systolic. And the diastolic blood pressure value was around 90 mmHg in the case group, whereas it was around 82 in the control group, sir.
Okay.
So what we included was approximately around 140 by any patient, usually above 140 was significantly at risk for developing an impairment.
Okay. What is your final recommendation? How to cut down smoking, avoid alcohol,
Yes, sir,
or cut down liquor and avoid smoking?
We would recommend on cutting down on smoking, sir. And when it comes to alcohol, as you said, it's quite controversial. So I think we need to refer more in that regard. So
Yeah, only one journal I have studied.
Yes, sir.
Nowhere I have studied this. I was surprised to read such a dare observation. And he is recommending people to go for alcohol.
That's quite interesting, sir. Yes. So
Yeah,
I think we can plan some study in future, sir, in this particular regard.
So social drinking and excess drinking.
Yes, sir. Exactly. Yeah.
Social drinking less than allowed quota, and people consuming more than what is required.
And then the people abstaining from alcohol.
You are from which place?
I'm from Hyderabad, sir.
Hyderabad.
Yes, sir. I'm from Hyderabad.
Okay, all the best. All the best.
Thank you so much.
Do well in your exams.
Thank you, sir.
Thank you.
Next one. Abstract number 179. Karthik Kumar.
Each person ki time ఎక్కువ వెళ్ళిపోతుంది.
Good morning, sir.
Yes. Karthik Kumar.
Yes, sir.
Yeah, you are from which place?
Narayana Medical College, sir.
Narayana.
Final
What
year.
is your study?
Study on clinical profile, sir. A clinical profile of cardiac syndrome in tertiary care center, sir.
Clinical profile. What is the
Cardiac
other names for?
syndrome.
What are the other names for syndrome X?
Coronary microvascular disease and chest pain with normal coronary arteries, sir.
No. Other syndrome related to syndrome X.
Metabolic syndrome, sir.
Metabolic syndrome. Any other names other than metabolic syndrome? Okay. What are your study observations?
Patients usually previous studies shown prevalence is more among females, sir, especially in
What is your observation? Not previous studies. What is
my
your present
observation,
study indicating?
In my present study, there is no significant difference between male and female predisposition, sir. And patient presentation is mostly of atypical chest pain, sir. And more than 60% patients are having STP changes, sir, with normal CAG, sir.
Okay. What is your recommendations?
Recommendation is most important risk factor for cardiac syndrome X or any other coronary artery disease is smoking, sir. Smoking cessation and regular exercises and treatment like beta blockers, sir. In some studies shown that ranolazine also useful in cardiac syndrome X, sir.
Okay. What is the number of patients you have studied?
410 patients, sir.
14.
410, sir.
410.
Yes, sir.
Okay. Good, Amma. All the best. Thank you.
Thank you, sir.
Next one. Abstract number 198.
Good morning, sir.
So, Dr. Deepthi.
Yes, sir. Good morning, sir.
Yeah. What is your study, Amma?
Occurrence of secure thyroid syndrome in ST elevation myocardial infarction and its prognostic significance, sir.
What is your observation?
We have taken 50 patients, sir. Out of them, 21 showed thyroid function abnormalities, sir.
Previously, there are not a known patients of hypo or hyperthyroid.
Yes, sir.
What do you mean by sick euthyroid?
Occurrence of thyroid function abnormalities in patients without any prior thyroid illness, sir.
So,
And
sick
generally,
euthyroid definition.
It's nothing but occurrence of thyroid function abnormalities in persons without any prior hypothalamic pituitary or thyroid gland dysfunction, sir.
Okay. So how many patients you studied the abnormal values of?
Okay. We have taken 50 patients with ST elevation MI, sir. Out of that, 21 patients they have showed thyroid function abnormalities, sir. They do not have any prior hypothalamic pituitary or thyroid gland dysfunction. Or they are not on any drugs which will affect thyroid.
What is your recommendations?
And we have also observed that as the severity increases, like as the Kilitz class increases, the positivity of secure thyroid syndrome increases, sir.
Okay.
In patients, even with when we also observed for the occurrence of secure thyroid syndrome in patients with ejection fraction less than 50 and greater than 50, sir. It is more in patients with ejection fraction less than 50, sir. And we also observed for the ICU stay, sir. In patients who are secure thyroid syndrome positivity, the mean duration of ICU stay is greater when compared to negative patients, sir. Even death is also observed in positive patients only, sir. And the most common thyroid hormone abnormality that we found is low T3, sir. And from this, we observed that
T4 are normal.
And more in that patients, T3, T4, and TSH are normal, sir. Out of 50
have gone for FT3, FT4s?
No, sir, only total T3, total T4, and TSH, sir.
We are supposed to do a free thyroid hormones, no? FT4 and FT3.
Those are not available in our hospital, sir.
No, finally, before you saying thyroid abnormality, serum protein values also will change your T3, T4 values.
Yes, sir. Yes, sir.
So finally, you are supposed to do a
free
T3, T4 before
concluding
marking as a sick thyroid.
Okay.
Okay, your observations. The low T3, they are associated with prolonged ICU stay and increased mortality.
Yes, sir.
So anywhere the T3, T4, TSH normal, T3 alone is low, especially in pregnancies. You are supposed to do a FT4, FT3s, right?
Yes, sir.
All the best, Amma. Thank you. Congratulations.
Thank you, sir. Thank you, sir.
Thank you.
Next one, abstract number 214. Nitish Gopal.
Dr. Nitish.
Sir, good morning, sir. I'm Nitish, sir. GSL from GSL Medical College, sir, Rajahmundry, sir.
Yeah. What is your study, Amma? Yeah, audible.
Evaluation of microalbuminuria in newly diagnosed hypertension.
What is your observation? How do you prevent this?
Sir, in our study, I have observed that we have taken a 50 sample size, sir, in which 14 patients were having microalbuminuria, sir. So, in the newly diagnosed hypertensive patients, sir. So, the newly diagnosed hypertensive patients are considered for the study, sir. And in that, we are calculating the microalbuminuria, sir. In that, if they have any microalbuminuria changes, sir, then we can say there is some end organ damage going on, sir. So we can be.
How do you prevent this?
Sir, we can use antihypertensives, that is ACE inhibitors and ARBs, sir, can be used in these patients, and the microalbumin and the end organ damage can be prevented, sir. So the target organ damage.
Have you followed these patients after giving your ACR, ARBs again?
Yes, sir. In some, no, sir. Actually, in our study, this I have not followed, sir. We have just considered. We have just considered, and we have. It's not a prospectus.
Okay. Congrats, Amma. Thank you very much.
Next, first 11th class Ashok Kumar Devakonda.
Yes, sir. I am here, sir.
Ashok Kumar Devakonda.
Yes, sir. Yes, sir. I'm here, sir. Good morning, sir.
What is your study, Amma?
Sir, my study is analysis of etiological features, clinical features, and complications of atrial fibrillation, sir.
How many patients you have taken?
Sir, 50 patients, sir.
What is the commonest cause?
Sir, commonest cause is rheumatic heart disease, sir. 65%, sir.
Rheumatic heart disease.
Yes, sir.
In rheumatic heart disease, which is the most common valve or abnormality?
Mitral valve, sir. In rheumatic heart disease, almost all patients mitral valve involved, sir. Both isolated MS, both MS and MR in 41%, sir. Isolated MS, 31%, sir.
What is the classical murmur of mitral stenosis?
Mid-diastolic murmur, sir. Sir?
So okay. Is there pre-systolic murmur with atrial fibrillation?
Pre-systolic murmur.
What happens to pre-systolic murmur?
Pre-systolic accentuation. Pre-systolic accentuation will be present, sir.
With atrial fibrillation.
No, sir. Left atrial contraction will not be there. Pre-systolic murmur will not be present, sir.
Will not be there.
Yes,
okay. What are the complications of atrial fibrillation?
Most common is heart failure, sir. Followed by cardiomyopathy.
How do you treat? Role of digoxin in these individuals?
Digoxin slows the AV node, sir. So that ventricle to prevent the ventricular tachycardia, we slow down the AV node using digoxin.
Ventricular tachycardia is different from ventricular rate.
Yes, sir. Ventricular rate, sir.
You cannot call it as ventricular tachycardia.
Okay,
to
sir.
decrease the ventricular rate, you can give Lanoxin. What are the other drugs? They decrease the ventricular rate.
For rate control, we can give calcium channel blockers like diltiazem, verapamil, beta blockers like cardiac specific beta blockers like metoprolol.
Okay, anything other than rate control you give? Any other things that prevent complications?
Anticoagulants, sir. Anticoagulants.
How do you monitor your anticoagulant therapy?
PTINR, sir. International normalized ratio and prothrombin time. Serially monitor.
What is the ratio you would like to maintain?
Between 2 to 3, sir.
Okay, Amma. So most common is valvular disease,
Yes, sir.
rheumatic heart diseases.
Yes, sir. Yes, sir.
Congratulations, sir. Thank you.
Thank you. Thank you, sir.
Next, abstract number 282. Soumya.
Dr. Soumya Javaji from GSL Medical College.
Please unmute.
Hello, sir.
Yeah, what is your study, Amma?
Sir, good morning, sir. My study is correlation of mean platelet volume as a prognostic indicator in acute coronary syndrome patients, sir.
How many cases you all studied?
Sir, we took 85 cases, sir.
How do you calculate mean platelet volume?
Sir, actually on PVP, the larger platelets are selected and the platelet volume is calculated, sir. And the mean of this platelets is taken, sir. Normally it is 7.5 to 12, sir. In our study in ACS in acute coronary syndrome patients, the mean platelet volume is ranging from 10.6 to 14, sir, and the mean is 12.46, sir. In control, we took 85 controls, sir, age and sex matched patients with non-cardiac chest pain. In those patients, the mean platelet volume is ranging from 9.3 to 14.3, sir. And the mean is 10.6, sir. So it
What is
is
your
there is
observation?
there is a significant correlation, sir, between mean platelet volume and acute coronary syndrome, sir. And the higher mean platelet volume, it is like an independent risk factor for MI, sir, and it is also correlated with the severity of atherosclerosis, sir, as it is usually
Can you
calculated on
no?
hemogram,
Can
and
you
it
treat
is,
this? Can
sir,
you treat this? Can you treat this?
actually it is just a indicator, sir, prognostic indicator, sir.
So no treatment is available to decrease the platelet volume.
No, sir.
Congratulations, Amma. Thank you very much.
Thank you, sir. Thank you, sir.
Network issue. Check number 299.
Dr. Venkatasarathi.
Yes.
Good afternoon, sir.
What is your study, Amma?
Good afternoon, sir. I am Sardi from GSL Medical College, and study is on influence of metabolic syndrome on clinical profile and outcome in patients with acute ST-elevated myocardial infarction.
2 minutes.
What is your observation?
We have taken 100 patients into
Tell
my
me your
study.
observation. Tell me your observations.
Out of 100 patients with ST-elevated myocardial infarction, 46 were fulfilling the criteria of metabolic syndrome, sir, and 54 were not fulfilling this metabolic syndrome criteria.
Yeah.
And among the 46% who are having a metabolic syndrome, more are in female groups, sir. In
What criteria have you taken to label as metabolic syndrome?
WHO criteria and IDF criteria.
What you have taken? What you have taken?
WHO criteria, sir.
What are they?
Elevated blood pressure, sir, greater than 160/90, and abdominal obesity with waist to hip ratio greater than 0.9, and BMI greater than 30 kg per meter square, sir, and low HDL cholesterol less than 35 in male and less than 39 in female, sir, and increased high triglycerides, sir, greater than 150, sir.
Hyperinsulinemia or impaired GTT?
Yes, sir.
Okay. What is recommended? What are your recommendations?
The study mainly recommends the lifestyle modifications in individuals, sir, which includes weight reduction, smoking cessation, and exercise.
Very good, Amma. Lifestyle modifications are important. Congratulations and thank you.
Thank you, sir.
Thank you. All the best.
Thank you.
Abstract number 1. 312.
Renuka, Dr. Renuka. ఇది 2 నిమిషాలేనా?
ఇది కూడా 2 నిమిషాలు.
Dr. Renuka from Rangaraya Medical College. Mr. Gautam.
Yes, sir. She's not in the meeting.
Available?
She's not in the meeting.
Not in the meeting, yeah?
Yes, sir.
Can mark as absent?
No, sir.
Yes, sir.
Zoom.
She is in Zoom, anta?
Yes, sir. She's in Zoom.
Call her.
Okay, sir. I'll call her. Renuka,
call her
please.
by phone.
Yes, sir. I'll call her.
చెవులు మాట్లాడిపోతున్నాయి.
ఈ అమ్మాయి గ్యాప్ అట్లా పెట్టేసుకుంటాను. దీనిని గ్యాప్
ఒకటోదని
1 19 గ్యాప్. ఇక్కడ ఒక అబ్బాయి 9 వెంకటేష్ సాయి సురేష్ నంబర్ ఇచ్చాను, మొబైల్ నంబర్.
వచ్చేసాడు కదా,
వచ్చాడు కానీ మనకి వాయిస్ వినపడలేదు.
అవును,
సో మళ్ళీ మనం నెట్ ఇష్యూస్ అని చెప్పి మళ్ళీ కొద్దిసేపు తర్వాత కాల్ చేస్తాను. నాకు కాల్ చేస్తాను. ఇది అబ్బాయికి అంతా రెడీ అయిన తర్వాత నాకు కాల్ చేస్తాను.
ఎవరినో చేసేసాం కదా మెసేజ్లతోటి.
మెసేజ్తో ఒక మెసేజ్ చేసాం. ఆ అమ్మాయికి మాత్రము మనం చాలా మెసేజ్తో.
గౌతమ్ గారు,
రేణుక
గారు వచ్చారండి.
రేణుక గారికి కాల్ చేస్తున్నాను.
అలాగే
మీరు నెక్స్ట్ వరకు వెళ్ళండి సార్. నెక్స్ట్ అబ్స్ట్రాక్ట్ నెంబర్ 337.
ఓకే,
రెడ్డి శ్రీనివాస
జయరామ్ నాయుడు. యా, రేణుక గారు వచ్చారంటే చూడండి.
రేణుక, ప్లీజ్ అన్మ్యూట్ యువర్ ఆడియో.
హలో సార్.
హలో రేణుక గారు.
సార్.
యా. What is your study, Amma?
Sir, my study was efficacy of late thrombolysis in acute MI patients, sir.
What do you mean by late?
After 6 hours, sir.
After 6 hours and up to how many hours?
24 hours, sir.
Up to 24 hours, not later than 24.
No, sir.
Okay. What is your observation?
Even if if giving late thrombolysis also, efficacy was good, sir. The hypotension and LV dysfunction, all post-MA effects are less if we given thrombolyze the patient before 24 hours, sir.
How many cases you have studied?
Total 149 patients, sir.
Late thrombolysis.
Yes, sir. I'm studying 149 patients, sir. It includes 4 groups, sir. First group was within 6 hours, sir. Group 2 was 6 to 12 hours, sir. Group 3 12 to 24 hours, sir. Group 4 non-thrombolyzed groups, sir. What I observed was in both the 3 groups, the side effects, post-MA effects are less when compared to non-thrombolyzed groups, sir.
Okay.
Yes, sir.
How many are early? Within 6 hours?
Yes, sir. Within 6 hours, 39 patients, sir.
39 patients. What drug you use commonly?
Commonly, we use injection streptokinase, sir. I use streptokinase in our setup. We use streptokinase, sir, to thrombolyze 0.5 million units, sir.
Okay. Do you give a test dose?
No, sir. I didn't get test dose, sir.
So suppose the individual requires a second time streptokinase, can it be given?
Yes, sir. Within 1 year we can give, sir, because antibodies formed are gradually wean off, sir.
Okay. After 6 months?
No, sir. Within 1 year, sir. After 1 year, we can give streptokinase patients, sir. We can give.
Within 1 year, you are not supposed to give. What is that you give? Suppose patient comes again with another MI.
We can give tentative plus also, sir, other thrombolytic agents, sir.
Okay. What is myocardial stunning?
Due to sudden ischemia, the myocardium unable to function.
Sudden ischemia.
Yes, the myocardial function was impaired, sir.
Okay. So have you seen complications due to thrombolysis?
Yes, sir. I saw. In my study, I didn't observe any patients, sir.
No complications of thrombolysis.
Yes, sir. In my study, no complications, sir.
Okay. What is the common complication?
Bleeding, sir. Intra-abdominal bleed or intracranial bleed, sir.
Yeah, congratulations. Thank you and all the best.
Okay, sir. Thank you, sir.
ఈ అబ్బాయి మరి సాయి సురేష్ ఆకుల
ఎంత?
సీరియల్ నెంబర్ 9.
సాయి సురేష్
ఓన్లీ పోస్టర్ ఉంది కదా.
Dr. Sai Suresh.
I'm audible to you, sir.
Yeah. What is your study, Andy?
Of albuminuria and its association with the cardiovascular disease, sir. And changes, sir. In pre-hypertension.
What is your observation?
Patients, in the study, sir, 50 subjects were selected, sir, who were either pre-hypertensive or pre-diabetics or both coexisting.
What do you mean by pre-hypertensive?
Sir, as per new JNC guidelines, sir, pre-hypertension is defined as systolic blood pressure in between 120 to 129 mm of Hg, sir, and diastolic blood pressure less than 80 mm of Hg, sir.
Diastolic blood pressure more than 80 or less than 80?
Less than 80, sir.
So that is the diastolic blood pressure is less than 80 and systolic blood pressure is more than 120.
120 to 129 mm of Hg, sir.
Non-diastolic is less than 80.
Yes.
Okay. We call them as pre-hypertensive. Pre-diabetes?
Pre-diabetes means either presence of either impaired fasting glucose, sir, or impaired glucose tolerance, sir, or HbA1c in between 5.7 to 6.5 grams per deciliter, sir. If the patient
what is your observation?
Sir, among these subjects, presence of microalbuminuria, presence of UPG changes and 2D echo changes suggest of cardiovascular disease was more in patients with microalbuminuria, sir, than with patients with normal albuminuria, sir. Therefore, microalbuminuria may be considered as biomarker for cardiovascular disease morbidity and mortality.
How do you treat?
Sir, by targeting microalbumin is considered as ideal target, sir, as a part of early primary prevention for cardiovascular disease, sir, by using the ACE inhibitors or ARBs, sir.
Okay. Congratulations. All the best.
Thank you, sir.
Next, serial number 20, sir.
So serial number 20, abstract number 337. He's not in the call. He's not in the call, sir.
Sir, am I audible, sir?
Introduce yourself.
Hello, sir.
Introduce
Hello,
yourself,
sir.
Amma.
Sir, I'm Dr. Srinivas Jairam Naidu, sir, from Bangarai Medical College, Kakinada, sir.
What's your study?
So my study is about ST segment resolution after thrombolysis, sir.
What is your study
acute
regarding?
MI. Am I audible, sir? Hello, sir.
Dr. Srinivas
Hello, sir.
Jairam Naidu.
Yes, sir. Am I audible, sir? Hello?
Go ahead, Amma.
ST segment resolution, sir. ST segment resolution after thrombolysis in acute MI, sir, as a predictor of outcome, sir. Hello, sir. Hello, sir. Hello, sir.
Hello. Yeah, please check your internet connection, please.
Hello, sir. Am I audible, sir?
You are audible, but please check your internet connection.
Hello.
Wait. Sir has left the meeting. He will join. Hello.
Hello, sir.
Hello.
Yeah.
Sir.
Chepandi, we have a network problem here. It is resolved. Go ahead. Dr. Jairam Naidu.
ST segment resolution after thrombolysis, sir, in acute MI as a predictor of outcomes, sir.
How many cases you have studied?
60 cases were studied, sir, between the period of November and April, sir, 2020 to 2021, sir. And the patients who
What
are
is your
included were.
observation?
Okay.
What is your observation?
Actually, patients are categorized into 3 categories, sir, based on ST segment resolution, sir, after 90 minutes, sir. Out of which category A was as a 30% resolution, sir, and 30 to 70% resolution of categories under category B, sir, and greater than 70% resolution was categorized under category C, sir.
Okay.
And the conclusion was about the patient with no ST resolution after 90 minutes following thrombolysis was associated with more frequent adverse events, sir, and increased mortality compared to the partial and complete resolution group, sir.
Those people who are not responded, at least partially also, they have
Yes,
more
sir.
complications.
Yes, sir.
So, okay. Very good, Amma. Congratulations and thank you.
Okay, sir. Okay.
Dr. Sindhura.
Good morning, sir.
What is your study, Amma?
My study is a study of diastolic dysfunction in newly diagnosed type 2 diabetes and its correlation with glycosylated hemoglobin, sir.
చూడమ్మా మీ ప్లేస్ లో ఇంకా సేమ్ పీపుల్ లాగిన్ అయి ఉన్నారా?
లేదు సార్.
మీ దగ్గర డిస్టర్బెన్స్ ఉంది మేడం.
హలో సార్.
ఎక్కువ వస్తుంది.
మీది ఆడియో ఎక్కువ వస్తుంది. చుట్టుపక్కల కనెక్ట్ అయి ఉన్నట్టున్నారు. రెండు డివైస్ లో కనెక్ట్ అయి ఉన్నారేమో. ఒకటి డిస్కనెక్ట్ చేసుకోండి.
అవును, 2 డివైస్ లో కనెక్ట్ ఉన్నారు మీరు.
ఓకే సార్. Sir, am I audible now, sir?
Yeah. Now you are clear. How many cases you have studied?
100 cases, sir. 100 cases of newly diagnosed type 2 diabetes, sir.
What is your observation?
My observation was out of 100, most 41% of the cases have type 1 stage 1 LV diastolic dysfunction, sir, and a minority of patients have
What do you mean by diastolic dysfunction?
It's a failure, left ventricular relaxation failure, sir. By 2D echo, like we have graded the patient from stage 1 to stage 4, sir.
Okay. So, is it related to your HbA1c?
Yes, sir. When we compared patients who have a grade 1 diastolic dysfunction with the mean HbA1c levels, it was found that HbA1c levels were it was positively correlated, sir. The patients with diastolic dysfunction have greater HbA1c levels.
Newly diagnosed type 2 diabetes mellitus, huh? Okay.
Yes, sir.
So, what is your recommendations? Diet control is essential to prevent cardiac complications.
Yes, sir. Diet control, lifestyle modifications, sir. And also, if the HbA1c is not controlled after 3 months of follow-up, then we can add on medications like metformin or any other oral hypoglycemic drugs.
So, these individuals are not on treatment, huh?
No, sir. They're newly diagnosed, sir.
Newly diagnosed without any treatment?
Without any treatment, at the onset of diagnosis, my study was to know the diastolic dysfunction in the new onset, so without any confounding factors like hypertension or dyslipidemia or anything. Only diabetes and its cause on left ventricular diastolic dysfunction.
And diabetes, that too, they are not on any treatment.
Newly diagnosed, so we'll start on treatment, but at present.
Okay. Very good, Amma.
Okay.
Congratulations and thank you.
Thank you, sir.
Next, serial number 23. Abstract number 345.
Okay. Sayarsha, he is local and we'll do it later.
Okay.
We'll go to 24.
Okay.
Santiram
Sai Venkat. Sai Venkat. Abstract number 345.
350.
354.
No, Sai Venkat is 350.
Okay, 350.
Yes, ma'am, you are.
Yeah, what is your study, Amma? Sai Venkat? Dr. Sai Venkat. Am I audible? Mr. Gautam, Sai Venkat is not audible. Only point the connection on. Sai Venkat,
sir.
go ahead. Yeah. What is your study?
Sir, good morning, sir.
Good morning.
Based on serum with acute myocardial infarction at Tertiary Hospital, sir.
How many cases you have studied?
Sir, I have studied 60 cases, sir, of which 25% of cases were 30 cases we studied with acute myocardial infarction, proceeding with arrhythmia, sir. And another 30% of patients we have studied with acute myocardial without arrhythmia, sir.
What is your observation?
Observation. Patients in whom the serum magnesium levels are very. Hello, sir.
మీ వాయిస్ ఫ్లక్చుయేట్ అవుతుంది.
Sir, now it's
మౌత్
audible,
పీస్
sir.
సరిగ్గా పెట్టుకోండి. యా అదే ఫ్లక్చుయేట్ అవుతుంది, హైస్ అండ్ లోస్. యా, గో హెడ్. డాక్టర్ సాయి వెంకట్, గో హెడ్ అమ్మా. సాయి వెంకట్.
Sir, now it's audible, sir.
Yeah.
Sir, patients acute myocardial infarction with low magnesium levels are prone to develop ventricular arrhythmia, sir, when compared to those who are having normal magnesium.
What do you mean by low magnesium levels?
When the magnesium levels is less than 1.6 milligram per deciliter, sir, serum magnesium levels less than 1.6 milligram per deciliter, sir.
Will you treat with magnesium?
Yes. So magnesium will play a vital role in preventing from ventricular arrhythmia, sir, in patients with acute myocardial infarction.
Okay. What is the reference?
Sir, so patients with magnesium replacement therapy will play a beneficial role in patients with acute myocardial infarction, sir, who is having low serum magnesium levels, to reduce the incidence of arrhythmia, sir.
Very good. Thank you, Amma. Congratulations.
Thank you, sir. Thank you very much.
Hello.
Sai Pavan.
Hello.
Dr. Sai
Hello?
Pavan.
Sir, I'm audible.
Hello.
Sir.
Yeah.
Okay.
Yeah, go ahead. What is your topic, Amma?
So, study of microalbuminuria in non-diabetic hypertensive patients and target organ damage, sir.
How many cases you have studied?
I studied 150 cases, sir. Out of 150 cases, 26 have LVH and 20 members have stroke and 24 members have retinopathy, sir. Microalbuminuria showed significant correlation with cardiac dysfunction and target organ damage.
Okay. Microalbuminuria, significant risk factor for target organ
risk and target organ damage.
Okay. How do you prevent this?
Sir, if a patient have hypertension, we'll give ACBs and ACAs and ARBs, sir.
Okay, Amma. All the best. Thank you.
Thank you, sir.
Sir, next is serial number 26. Abstract 376. Teja.
Dr. Teja. Dr. Teja, M. Teja.
Teja Manipuri.
Sir, I'm audible, sir.
Yeah. Go ahead.
Good morning, sir. Sir, my topic is
Estimation of cardiac troponin T levels in acute myocardial infarction patients with reference to short-term prognosis, sir.
How many cases you have studied?
50 patients, sir.
What is your observation?
Out of 50 patients, 3 patients had a ST elevation MI and remaining 17 patients had non-ST elevation MI. Male patients are more common than
What is
female
the relation
patients,
between troponin levels and your prognosis? Your observation.
Patients in patients with elevated troponin T levels, 50% of patients experienced complications, sir. Whereas in patients with normal troponin T levels, only 12% patients experienced complications.
So, is there any range of troponin that the more the troponin, the more severe are the complications? Have you observed any cutoff values?
So, if troponin levels are more than 0.22, sir, and the complications are more, sir.
Okay. Suppose the values are more than 10, more than 20, more than 30, like that. Have you categorized into various groups? You are telling more than.
Troponin levels than.
Yeah. Your audio is not there. Dr. Teja, your audio is not audible. Have you categorized troponin levels and the risk factors? Risk of bad prognosis. Suppose the range of troponin.
Sir, if troponin level is less than 0.01 nanogram per ml, sir, complications are relatively less, sir.
Okay. And if the troponin is more, complications are more.
Complications are more, sir.
My question is, in these troponin levels, more values, have you categorized them, subgrouped them into mild, moderate, high rise of troponin?
Sir.
Not done
less
like
than
that.
0.01, sir, and 0.01 to 0.03 nanogram per ml, sir. And next group is 0.03 to. Sir.
So, what are the prognostic parameters you have studied?
For complications like post-infarction angina, recurrent infarction, heart failure, and death, sir.
No, you tell the short-term prognosis you have studied.
Sir.
Acute complications of MINT. Acute MI and its complications, not on long-term prognosis. Arrhythmias and
cardiogenic shock, acute LV dysfunction. Cardiogenic shock.
Yeah, acute LV dysfunction, cardiogenic shock, and arrhythmias, they are the acute complications. Right, very good, very good. Congratulations, Amma.
Thank you.
Dr. Kausalya.
Yes, sir. Am I audible, sir?
Yeah.
Good afternoon, sir.
What is your study, Amma?
My study is on incidence of microalbuminuria and left ventricular hypertrophy in hypertensive patients, sir.
What is your observation?
Here I had found that about 22% of the cases are having microalbuminuria, sir, and 20% are having left ventricular hypertrophy, sir. And there is a strong statistical association with microalbuminuria with age-6 and diastolic blood pressure, sir. And the left ventricular hypertrophy is also having a strong association with diastolic blood pressure, sir.
Okay. What are the drugs that prevent microalbuminuria?
AC inhibitors and ARBs, sir.
Okay. Very good. Congratulations, Amma.
Yes, sir. Thank
All
you,
the
sir.
best. 390. Nityata. Dr. Nityata.
Sir, good afternoon, sir. Am I audible, sir?
Yeah. Go ahead, Ammo. What is your topic, Amma?
My topic is serum calcium in newly diagnosed essential hypertension, sir.
Yeah. What is your observation?
Serum calcium is significantly less among hypertension patients, sir, and it is correlated negatively with the blood pressure, sir.
So, mean to say?
So calcium-rich diet will be useful for both prevention and control of essential hypertension, sir.
And you give calcium blockers and high-rich calcium.
Calcium-rich diet, sir.
Calcium-rich diet with calcium blockers.
Sir?
Right? Treatment is calcium blockers. Diet is calcium rich.
Yes, sir.
Okay. Tell me some causes of hypercalcemia.
Parathyroidism, sir, and tumor lysis syndrome, sir.
Tumor lysis is hyperuricemia or hypercalcemia?
Hyperuricemia, sir. And
sarcoidosis, multiple myeloma, vitamin D intoxication, milk alkali syndrome. 1 minute.
మీకు నేను వాట్సాప్ పెట్టేసాను అది రమణ్ రావు సార్కి పెట్టేస్తే ఆయన చదివి వీడియో రికార్డ్ కరెక్ట్ రివైజ్
చూసండి ఓపెన్ చేసి చూసండి Yeah. So newly diagnosed hypertensive, sir?
Yes, sir.
Okay. What is the cutoff value you have taken to diagnose hypertension?
More than 120/80, sir.
ఏంది రెండు ఆయన పంపించారు మనకి మీరు పంపారా
రివైజ్ చేశాను
మీదేనా ఇది కింద
అది నేను రివైజ్ చేసింది
రెండు పెట్టి పంపించాలా రెండునా
ఎవరికి పంపాలో
రమణ్ రావు గారికి
అయితే పంపించాను కింద డౌన్లోడ్ అవ్వలేదు ఫస్ట్ పంపించేసాను
మీరు ఓపెన్ చేయండి Yeah. So what criteria have taken for diagnosis of hypertension?
JNC criteria.
What values you have taken? What is the systolic cutoff and what is the diastolic cutoff?
More than 120, sir. Diastolic more than 80, sir.
మీరు తీయాలి కదా
నేనే పంపించాను
రైట్ అది ఓపెన్ చే ఇది కాపీ చేస్తారా 1 minute తల్లి కాపీ అవ్వలేదు
ఇందాక చేశారు
ఇది కూడా రమణ్ రావు గారికి పంపించాను
చెప్తాలి సారీ ఓకే వాట్ ఇస్ ద సిస్టోలిక్ కట్ ఆఫ్ వాట్ ఇస్ ద diastolic కట్ ఆఫ్
Sir, am I audible, sir?
Yeah, very much audible, Amma.
For stage 1 hypertension, it is like more than 139, sir.
Okay.
And diastolic is more than 90.
More than 90, yeah?
Yes, sir.
90 and above.
90 and above.
Okay. So, what is your recommendations finally?
To consume a calcium-rich diet, sir, in order to prevent and treat essential hypertension.
Calcium rich. Any other minerals help in preventing hypertension? Any other electrolytes?
Low sodium diet, sir.
Low sodium, rich diets. Fruits,
Yes, sir. High potassium.
high potassium, also helpful. Very good, Amma. Thank you.
Thank you.
29. Dr. Taslim.
Hello, good afternoon, sir.
Yeah, go ahead, Amma.
I'm Dr. Taslim Sulaika, second year postgraduate. My topic is cardiovascular manifestation in hypothyroidism, sir. I have studied 50 patients with who was diagnosed to have hypothyroidism, and I found that there are about 42% of the patients are having bradycardia, hypertension, muffled heart sound, elevated GDP, and in ECG findings showed that bradycardia, low voltage ECG complex. Echo findings showed 32% of the cases are having pericardial effusion, diastolic
Gautam, your
dysfunction,
voice
sir.
is coming. Yeah.
Majority of the patient belong to age group of 31 to 50 years of age, sir, in my study, and I found that bradycardia was encountered in 42% of the study group, and 34% of my study group had low voltage complexes, and 32% of the cases have pericardial effusion, sir, and 24% of the cases have diastolic dysfunction, sir. Yes, sir.
Have you taken 2D echo?
Yes, sir.
So any pericardial effusions?
Yes, sir.
How many?
32% of my patients have pericardial effusion, sir.
Dedication. What are your suggestions?
So I wanted to say that when our patient come to us with a symptom of hyperthyroid, such as easy fatigability, weight gain, hair loss, while we do for thyroid function test, if we do cardiac studies such as ECG, echo, since early recognition and aggressive management can reverse the disease and prevent the cardiac complications.
Okay. Congratulations and thank you.
Thank you, sir.
Next one, 441. 412, abstract number.
Dr. Sheikh, Narayana Medical College.
Good afternoon, sir.
Yeah.
I am
What's your name,
Shahla, third year PG. I am Shahla, sir. Third year PG from Narayana Medical College, sir.
Yes, go ahead, Amma. What is your study?
My study was C-reactive protein levels in acute coronary syndrome and its significance in prognosis, sir.
What is your observation, Amma? How many cases you have studied?
I have studied 50 patients, sir. Of these
What is your
patients,
observation?
36 patients had raised serum creatinine levels, sir. That is more than 0.6 mg per DL.
What is your
Of the
recommendation
total
finally?
in patients with the raised C-reactive protein levels, they are more prone for complications and have poor prognosis, sir. So aggressive management should be done, sir.
So do you decrease the CRP levels, sir?
No, sir.
Decrease the CRP and
It will
complications
guide
will
for
be less.
it will guide for therapeutic
Guide
management.
Okay. Thank you, Amma. Thank you. All the best.
Thanks.
Dr. Venkata Harshita.
Yes, sir. Good afternoon, sir.
Good afternoon. Yes, go ahead, Amma.
Sir, my topic is abnormalities in the echocardiographic findings in metabolic syndrome,
How
sir.
many cases you have studied?
Sir, a total of 100 cases, sir. I've included males and females. Sir,
What is the most common abnormality you made out?
most common, I've noticed diastolic dysfunction in 54% of my cases, sir. And also through echo, the parameters like left ventricular mass index, and relative wall thickness were significantly increased, sir, in patients with metabolic syndrome.
Okay.
And there is
So what is that?
and there is
What is
concentric
the final
remodeling was
impression you
present,
give?
sir. So my final
What is
impression
the-
is there is significant diastolic dysfunction, sir, and also there is concentric remodeling more compared to concentric hypertrophy, sir, in patients with metabolic syndrome.
Okay. Congrats and thank you.
Thank you, sir.
Next abstract number 440, Meghana.
Good afternoon, sir.
Dr. Meghana?
Good afternoon.
Dr. Meghana, your audio is not clear.
Dr. Meghana, please connect to your proper internet.
Hello.
Yeah. Go ahead, Amma.
Good afternoon, sir. I'm Dr. Meghana, second year medicine PG.
Meghana, your audio is good.
Serum uric acid.
Dr. Meghana, your audio is disturbed.
Hello.
Yeah. You are audible.
My topic is serum uric acid as a prognostic factor in acute myocardial infarction, sir.
Yeah.
And from the study, I have concluded that serum uric acid is higher in patients of acute MI as compared to normal healthy patients, and it can be used as a prognostic marker along with Phillips class comparison.
How many number you have studied?
My study population is of 50 patients of MI within 24 hours of onset, sir, and 50 normal healthy individuals.
What is the highest serum uric acid level you found?
11.5, sir.
Do you treat?
No, sir. This is just used as a prognostic factor, sir, but we can give a medication, sir.
At the time of discharge.
Yes, sir.
Okay, Amma. Thank you and congrats.
Next one, abstract number 344, Yamuna.
Good morning, sir.
Yamma, good morning. What is your topic?
So my topic is study of serum uric acid levels in essential hypertension, sir. I have taken.
What is your observation?
Sir, uric levels were found to be higher in individuals with hypertension, and even with the stage of the hypertension, the levels were increased, and even with the duration of the hypertensive period, there was an increase in serum uric acid levels, sir, which may be taken as a prognostic factor for increased risk factor for coronary artery diseases, sir. With him.
How many cases you have studied?
I've taken 120 individuals, sir, of 60 were cases and 60 were controlled, sir. These cases were hypertensive individuals, sir.
Okay. So you have got a positive correlation.
Yes, sir. Positive correlation.
Congratulations, sir. Thank you.
Thank you, sir.
Next one, abstract number 461.
Dr. Amulya.
Good afternoon, sir. Good afternoon, sir.
Yeah.
Sir,
What is
I'm
your
Dr.
study, Amma?
Sir?
What is your study?
Sir, my study is prognostic significance of serum uric acid levels in heart failure, sir.
What is your observation?
Sir, my observation, serum uric acid levels are relatively higher in patients with heart failure, And with the increase in the class of NIHA, serum uric acid levels also increases, sir. And after treating them with giving treatment to decrease uric acid levels, increased had better outcomes, sir.
So along with decongestive therapy, individuals who found to have high uric acid levels,
yes, sir,
you are treated with either febuxostat or
febuxostat,
allopurinol.
Allopurinol.
Okay. Very good, Amma. Thank you.
Thank you, sir.
Dr. Sneha.
Good afternoon, sir. I'm Dr. Sneha, sir. Hello, am I audible, sir?
Yeah, you are audible. You talk to your HOD. Sneha.
Chepu, Sneha.
Sir.
Ready?
Serum calcium and newly diagnosed essential hypertension, sir.
Essential hypertension.
Yes,
Okay.
sir.
Okay. So your observations?
My observations is serum calcium was found to be lower in hypertension, sir, and it's found to be lower in stage 2 hypertensive as when compared to even stage 1 hypertensive, sir. 70 cases were taken as cases, sir, and 30 were controlled, sir. In controls, the serum calcium levels was in normal range, sir. In the cases, it was lower, sir.
So usefulness of this study?
It can indicate that serum calcium is related in the pathophysiology of essential hypertension, sir. One of the theories that low serum calcium may stimulate the parathyroid hormone, which can lead to increased intracellular calcium, which leads to increased peripheral resistance, leading to increased blood pressure, sir.
Okay. So in that way, it is related.
Theory, sir. Yes, sir.
So in the treatment of essential hypertension, whether the alteration of the serum calcium has any role?
Yes, sir. We use calcium channel blockers are used, sir, but that also inhibits the extracellular calcium.
Intracellularly.
Yes, sir.
Okay. Thank you, Amma. Thank you. Carry on.
Thank you, sir.
Next abstract number 462. Vinod Kumar.
462. Dr. Vinod Kumar.
Sir, good afternoon, sir.
Yeah.
Hello, sir. Can you hear me, sir?
Yeah. What is your topic? What is your presentation?
Sir, my topic is admission hyperglycemia as a prognostic marker for acute ST elevation myocardial infarction, sir.
What is your observation?
Sir, my observation was admission hyperglycemia has increased the complications in diabetic and non-diabetic patients with acute myocardial infarction, sir.
So whether the patient is diabetic or non-diabetic at the time of presentation, if blood sugars are high, what do you mean by hyperglycemia? What is the cutoff value you have taken?
Sir, FBS was 120, sir, and RBS or TPBS was 140, sir, cutoff.
Cutoff you have taken.
Yes, sir.
So what is your inference and what is the observation? Inference, what is that you want to suggest?
Sir, at the admission hyperglycemia, sir.
So,
hello.
Prognostically, it is significant?
Yes, sir.
So, what complications you have observed with high values
sir,
of blood glucose?
Sir, I have taken 50 patients in the study, sir. In that, I have divided into two groups, sir. The persons who are less than 180 milligram per DL, sir, and more than 180 milligram per DL, sir. In more than 180 milligram per DL, sir, I have seen arrhythmias and heart failure and death, sir. I have seen arrhythmias in 8 patients, sir, and death in 1 patient, sir, and congestive heart failure in 4 patients, sir. Yes, sir.
All with hyperglycemia.
Yes, sir. All are hyperglycemia, sir.
No untoward events in individuals with euglycemia?
I've taken only the patients with more blood sugar, sir.
Euglycemia, and you have to compare now euglycemia and MI.
Sir, what I've taken patients are admission hyperglycemia patients, sir. All the 50%
Okay. Controls,
are.
controls you are not kept.
No, sir. Only admission hyperglycemia 50 patients, sir.
Okay. Controls without hyperglycemia.
Sir,
with MI,
I've compared patients with 1 year sugars of 180 milligram per day, less than 180, sir, and more than 180, sir. And based on sex, age, and HbA1c levels, sir.
Okay. Okay. Thank you, Amma. Thank you.
Thank you, sir. Thank you, sir.
Arun Kumar.
Dr. Arun Kumar.
Morning, sir. Am I audible?
Yeah. Yes, go ahead. What is your study?
Yes, sir. Actually, my study is a cross-sectional study of cardiac function in chronic obstructive pulmonary disease, sir.
What is your specialty?
Cardiology, sir.
General medicine?
General medicine, sir.
General medicine. Not a respiratory postgraduate.
No, sir. General medicine graduate, postgraduate.
Yeah. What are your observations?
Sir, my observations are included under I assist cardiac function in COPD with electrocardiography and 2D echo, sir, with a 6-minute walk distance test and board index.
No, what are your observatory findings? Not I am talking under which headings you have studied. What abnormal cardiac function you have noticed in your study?
Sir, in this, a simple tool was detected excess capacity of COPD patients and correlated with signs of right ventricular dysfunction, sir.
Are there any arrhythmias in your study?
No, sir, no arrhythmias, sir.
So, COPD is related to any arrhythmias?
No, sir, only cor pulmonale, sir. Not related to any arrhythmias.
So, COPD, no, you don't see any arrhythmias in COPD?
No, sir.
Okay. So, cor pulmonale is a common complication.
Yes, sir, most common, sir.
What is MAT?
Mean arterial pressure, sir.
MAT, not MAP.
MAK, sir. Sir.
What is MAT? MAT, multifocal atrial tachycardia.
Multi-atrial tachycardia, sir.
Multifocal atrial tachycardia.
Okay, sir.
Is it related to COPD?
Yes, sir.
You said no arrhythmias with COPD. Which year you are, Dr. Arun?
First year, sir.
First year postgraduate. Okay, Amma. Congratulations.
Okay, sir.
Thank you.
Thank you.
Hello, sir. Good afternoon, sir. My name is Harish, sir. Sir, am I audible to you, sir?
Yeah. Parese Harish. Harish?
Yes, sir.
Surname is Parese?
Yes, sir.
You are from which place?
Sir, I am from Nellore, sir. I am from Narayana Medical College, Nellore, sir.
Native of?
Native of Anantapur, sir.
Anantapur, right. Yeah. What is your study?
Sir, my study topic is serum magnesium as a predictor of the development of arrhythmias in patients with acute myocardial infarction, sir.
What is your observation?
Sir, out of the 50 patients I have studied, 25 patients with low serum magnesium levels have developed ventricular
magnesium values?
Sir, magnesium cutoff value is I have taken 1.6 as low cutoff, sir, and 1.6 to 2.4 is in normal range, sir. The patients
Do you give magnesium?
Sir?
Do you give magnesium for arrhythmias?
Yes, sir.
With hypomagnesemia?
Hypomagnesemia, IV magnesium sulfate, 4 to 6 mg loading dose followed by infusion can be given, sir, in the treatment
What
of
other indications you use magnesium IV?
Sir,
In
magnesium
what other
sulfate can be
indications?
used in eclampsia, sir, in seizure management and
Any
symptomatic.
respiratory diseases? Symptomatic?
Sir, symptomatic hypomagnesemia, sir. In the cases of seizures, patient developed, any pregnant woman developing seizures, or
Okay. Can it be given in like bronchial asthma?
yes, sir.
Role of magnesium in bronchial asthma. Ananda?
Yes, sir.
Yeah. So you observed chipid. You observed around 30 patients with
Yes,
low
sir.
magnesium and ectopics.
25 patients with low magnesium
25.
values. Yes, sir.
And ectopics.
They developed, yes, sir. They developed arrhythmias like VPCs and ventricular fibrillation, sir. When compared to other 25 patients who are in normal
When do
range,
you
they
say
do not
the ectopics are malignant? Malignant ectopics.
Sir, they may be
Benign
associated.
ectopics, benign ectopics and malignant ectopics.
Sir, in malignant.
Benign, malignant. Ectopic is benign.
Yes,
the
sir.
other ectopics, you say they are malignant. Malignant means they can lead to significant complications and dangerous.
Yes, sir. Yes.
Benign or they are less
They benign or
significant, it
non-benign.
can be ignored.
Yes, sir. Yes, sir.
Can you answer? Malignant
yes.
ectopics.
Sir, ventricular fibrillation can be malignant ectopic, sir. In which
Ventricular
ventricular
fibrillation is abnormal rhythm.
Yes, sir.
It is not ectopic, no?
Yes, sir. Yes, sir. Yes, sir.
What happens if there is a R on T phenomena? What is R on T phenomena?
Sir, RNT phenomena is the superimposition of ectopic beat on the T wave of preceding beat, sir.
What does it signify? It can lead to?
Sir, it may lead to acute MI, sir.
No, arrhythmias, tachyarrhythmias.
Yes, sir, ventricular tachyarrhythmias.
So couplets, triplets,
yes,
right? Multifocal ectopics, R-anti phenomena, they are bad prognostic factors for a ectopic. They are serious. Yes. You have to take care of them.
Lowndes classification. Lowndes classification. నువ్వు చెప్పినట్టు ఆర్ఎన్టీ
Okay, go ahead.
Yes, sir.
Thank you.
Thank you, sir.
Yeah.
Sir, good afternoon, sir.
ఏం బుక్?
నా పీజీలు అడిగాను చెప్పలేదు మళ్ళీ బుక్ లో తీసుకెళ్ళి.
Yeah, what is your study, Amma?
Sir,
Dr. Gautam.
Sir, analysis of most common risk factors and clinical profile of myocardial infarction in young people, sir. Less than 40
Okay.
years.
Less than?
Sir, 40 years I have taken, sir.
40 or 45 young and
I have taken less than 40.
Okay.
Sir, my conclusion, sir, most common symptom was Ambapuram, sir.
Okay. ఇంటి పేరా?
Yes, sir.
ఏదో గౌతమ్ కుమార్ ఫ్రమ్ అమలాపురం బదులు బి పెట్టామో అనుకున్నాను. ఓకే, వాట్ ఆర్ యువర్ అబ్జర్వేషన్స్?
So the most common symptom was chest pain, sir, and
రిస్క్ ఫ్యాక్టర్స్ కదా?
Yes, sir.
మోస్ట్ కామన్ రిస్క్ ఫ్యాక్టర్స్ ఏంటి?
Yes, smoking was the most common risk factor, sir. In 80% of, I have taken 100% of patients, 100 people, sir, 100 patients, and smoking was the most common risk factor, sir. It is 80% of people, sir, patients, and hypercholesterolemia in 82% patients, sir, and hypertension in 66%, and obesity in 66% patients, sir.
Alcoholism?
Sir, alcohol have a controversial effect on myocardial infarction, so we thought of making a thesis project on it, sir. We are doing on. Sir, I have not taken alcohol. Yes, sir.
You are not kept as a risk factor.
Yes, sir. We are making thesis on alcohol effects on myocardial infarction.
Okay. 1 minute, Gautam.
Yes, sir. Yes, sir.
Cheppamma. Okay, Gautam.
Sir, yes, sir.
Eన్ని cases study చేసావు?
100 cases, sir.
100 cases.
Yes,
Okay.
sir. Among them, 88%
Smoking in
males.
80%,
Smoking in 80%, sir. Males were 88, sir, and females are 12
Okay.
people.
Okay. Congratulations and thank you.
Thank you, sir.
Dr. Monica.
Good afternoon, sir.
Yeah, what is your study?
Sir, good afternoon, sir. I am Dr. Monica from NRI Medical College,
Yeah.
Vizag. My study is on acute coronary syndrome in young, sir, and I have correlated this ACS with angiogram profile, sir. Like in our hospital, in our setup, sir. So finally, like I got the result that ACS in young, the most commonly, if you observe it in angio, that single vessel disease is most common, sir. Whereas if ACS occurs in elderly, it is triple vessel disease that is most common, sir. And even in
How many cases you have studied?
young, sir, I have observed for 1 year, sir. In 1 year, 1100 cases I have seen, sir.
1100 cases.
Every case, like, yes, sir. And we have done angio, sir, for all these cases. And
Okay.
we have done angio, sir. Like in that, in young adults, if we get ACS, that left anterior descending artery is the most commonly involved.
Okay. Thank you.
And
Congrats.
I have also, thank you,
Okay.
sir.
Anything else you want to focus?
Sir, risk factors also I have observed, sir. That's
Yeah.
modifiable and non-modifiable risk factors I have observed, sir.
What is the most
Modifiable
common risk factor you observed?
Smoking is the most common, hypercholesterolemia are the second most common cause, sir. Non-modifiably, age, ethnicity, race, and genetic factors are most common, sir.
Okay. Congratulations and thank you.
Thank you, sir.
Thank you, Amma. Dr. Satsai Suhas.
Good afternoon, sir.
Yeah, what is your topic presentation?
Myself, Satsai Suhas from NRI Medical College, Mangalgiri, sir.
What is your study?
It's a study of echocardiographic changes in patients with chronic kidney disease. So it's basically a prospective cross-sectional study, sir. So the
What is your observation?
Sir, I have studied a total of 50 patients, sir. Duration of 1 month, sir, from July 2021 to August 2021. So I have
Only
observed
1 month study.
Sir.
Only 1 month study.
Sir.
Which year postgraduate?
I'm final year, sir.
So, only 1 year study you have taken, huh?
Sir, actually, yes, sir. So
1 month
50
study.
patients. Sir, from actually it is from yes, sir. So in nephrology clinic and wards. So
Okay,
50
what are your
patients.
findings? What are your findings? Most
So
common
inclusion-
abnormality?
There was pedal edema, sir. Study included a total of 50 patients, sir. Of those, 36
No.
were, sir.
Pedal edema may be due to cardiac, nutritional, renal kada.
Sir.
Echocardiographic abnormalities your study.
Pericardial. pericardial effusion was found in 22 cases, sir.
Okay.
44%. And it was the most common abnormality in this study, sir. And there was a concentric left ventricular hypertrophy was also detected, sir, in 20 patients, sir. That is 40% of the patients, sir.
What is that you do for pericarditis or pericardial effusion?
Pericardial.
Okay. What other observations? Concentric LVH, pericardial effusion. Any left ventricular dysfunctions?
Dilated and yes, sir. Dilated left ventricle occurred in 20% of the patients, sir, and diastolic dysfunction was seen in 26%, sir, and systolic dysfunction was seen in 22%, sir.
What is the common cause of death in CKD?
Can be the patients will have anuria.
They die of cardiac disease.
They can have a cardiac failure also, sir.
What is the most common cause of death in CKD? Is it renal cause or cardiac cause?
It can be due to renal involvement, sir. The patients
Most
will
common cause of death.
Hypertension causes CKD. So, heart disease, cardiovascular cause is the major
Major cause of death. Then renal causes.
Renal
right?
causes. Yes, sir.
Thank you. Thank you.
Sir. Thank you, sir.
Dr. Aparna.
Sir, good morning, sir.
You are from which college, Amma?
Good morning, sir.
Good morning. You are from which college?
Kurnool Medical College, sir.
What is your
Kurnool
topic,
Medical
Amma?
College, sir.
Yeah.
Sir,
What is your
evaluation
topic?
of cardiac diastolic dysfunction. Sir, hello, sir.
Hey, yeah. You are audible. Evaluation of cardiovascular.
Cardiac diastolic dysfunction in patients with and without diabetic nephropathy, sir.
With and without diabetic nephropathy, cardiac evaluation.
Diastolic dysfunction, sir.
Yeah. How many cases you have studied?
Sir, total 150 cases with type 2 diabetic included in this study, sir.
Diastolic dysfunctional.
Sir,
Diabetic
in
and
that,
non-diabetic.
yes,
What is
total
your observation?
150 cases, sir. In this, among 67 cases with nephropathy, in that 41 cases have diastolic dysfunction, sir.
So, what is your inference?
Sir, there is association between common pathological mechanism shared in diabetic nephropathy and diastolic dysfunction, sir. Increased morbidity and mortality, sir. In
So, you
patients with
compared with non-diabetic individuals, sir?
Sir?
You
Sir, no,
compared
sir.
them
With
with
diabetic nephropathy and without diabetic nephropathy, sir.
with and without diabetic nephropathy. Okay. Very good. Congrats and thank you.
Okay, sir.
All the best.
Haripriya is joining.
Mali cheppa Gautam tatu. Gautam garu?
Sir, Haripriya is joining.
First candidate వస్తున్నారా?
వస్తున్నారండి sir. 1 minute.
Okay. అక్కడ ఎందుకు వచ్చేసింది రేవతి అని వచ్చేసింది నాకు దాని మీద అదే అంటున్నాను Dr. Haripriya.
Hello, sir.
Yeah.
Sir, 2 minutes, sir. She's having some network issues. 2 minutes.
లేకపోతే ఆడియో కాల్ చేసేమనండి డాక్టర్ గారి నంబర్కి.
సార్ మ్యామ్ నీకు నంబర్ ఇస్తాను, ఆ నంబర్కి కాల్ చేసి.
అమ్మాయికి ఇచ్చారా నంబరు?
ఇస్తున్నాం సార్.
అయిపోయారా? అందరూ అయిపోయారా? ఆయన సత్యనారాయణ దర్శనరాజు గారు అయిపోయారా? ఓకే ఓకే సార్.
సార్ ఆమె కాంటాక్ట్ అవుతారు సార్ మీతోని ఆడియో కాల్.
ఓకే ఓకే ఓకే
ఓకే సార్.
ఆడియో కాలా?
అవును సార్, ఆడియో కాల్ కాంటాక్ట్ అయ్యింది.
కాల్ చేస్తున్నారా?